Traumatic heart disease. Traumatic heart disease is often fatal. Rapid diagnosis and intervention are vital to reduce both mortality and morbidity. Etiology: road traffic accident. Assault, non-penetrating or penetrating, including stab and gunshot wounds. Sports injuries. Falls. Iatrogenic, catheter, pacing or implantable cardioverter defibrillator lead or pericardiocentesis induced, or post-cardiopulmonary resuscitation. Pathophysiology and pathology. Virtually all cardiac components may be affected by thoracic trauma. Myocardium, contusion, approximately 20% of patients after blunt trauma, and laceration and pericardial tamponade or rupture, ventricles more than atria, and interventricular septum, 80% of stab wounds will present with tamponade. In the acute situation, as little as 100 ml of blood is required to cause tamponade. Pericardium, pericarditis, laceration, or post-pericardiotomy syndrome. Endocardium, ruptured chordae of papillary muscles or valve leaflets and cusps. Coronary arteries, injury or rupture or thrombosis, left anterior descending artery most commonly. Conduction system, bundle branch block, atrioventricular, AV, block or atrial and ventricular arrhythmias. Thoracic vessels, trauma to the aorta carries a very high mortality, Table 37. Clinical presentation. The initial insult is usually obvious and leads directly to presentation. Occasionally, apparent minor trauma causes significant mediastinal injury, leading to a more insidious presentation. Chest pain, including angina. Presyncope or syncope. Physical signs. Look for the following: hypotension, pulsus paradoxus, muffled heart sounds, pulmonary edema, murmur and thrill of mitral regurgitation, diastolic murmur of aortic regurgitation if ascending aorta involved, absent or abnormal peripheral pulses. Investigations. ECG. Look specifically for the following: ST&T changes, may be nonspecific, ST elevation secondary to pericarditis or acute myocardial infarction. Conduction abnormalities, bundle branch block or any degree of AV block. Arrhythmias, sinus tachycardia, atrial fibrillation, ectopic beats or ventricular arrhythmias. Cardiac enzymes. Commonly raised following cardiac trauma but only have prognostic relevance if related to coronary artery trauma. Elevated creatine kinase myocardial bound fraction, may be elevated if there has been huge musculoskeletal trauma. Elevated troponin. Chest radiograph. Widened mediastinum, Fig 79. Ribs or sternal fracture. Hemothorax. Echocardiography, transthoracic and transesophageal. Pericardial effusion. Abnormal wall motion, coronary artery involvement. Transesophageal echocardiography is best for identifying myocardial injury and valvular involvement. It is contraindicated in the following circumstances: severe facial trauma, cervical spinal injury, possible esophageal injury. Aortography. Aortography is usually considered the gold standard for diagnosing aortic trauma, Fig 80. Damage is most commonly seen in the upper descending aorta, at the site of the ligamentum arteriosum. Cross-sectional imaging is helpful in identifying surrounding hematoma. CT is generally performed as the scan is quicker than MRI. Radionuclide imaging. Reduced myocardial perfusion with contusion or ischemia secondary to coronary thrombosis may be demonstrated. Treatment. Each patient must be individually assessed. Patients can be broadly separated as follows. Low risk, minor trauma and normal or abnormal ECG. High risk, major trauma with associated thoracic or extrathoracic injuries and normal or abnormal ECG. Emergency. If there is hemodynamic compromise, consider urgent pericardiocentesis or operative intervention for pericardial tamponade. If there is any doubt, seek immediate contact with a cardiothoracic surgical center. If all investigations demonstrate no need for surgical intervention, then gentle mobilization is encouraged. If there is evidence of possible coronary artery and conduction system injury, then these will need evaluating further.